What if I tell you that there is an innovation that will allow you accuracy and precision in the diagnosis of an illness, and a more targeted and individualized treatment of patients with certain disease conditions, like depression? Hello, my name is Althea Sean, and my presentation today focuses on the role of pharmacogenomic testing, specifically gene site testing, in the management of patients with depression. I am currently doing my practicum at a family medicine clinic in the Midwest. Do you know that according to Greenberg in 2015, there is an estimated 16 million Americans suffering from moderate to severe depression, and the direct cost, including workplace costs, is a staggering $210 billion. How can we, as nurse practitioners, help lower these costs? I believe that one of the answers is through personalized medicine and pharmacogenomic testing. I will explain to you on the later slides, but first, let me tell you why my interest on depression and pharmacogenetic testing. My genuine interest in personalized medicine was because I believe that it is the future of family medicine and of healthcare as a whole. My grandfather had lung cancer, and when I heard that through genetic engineering, we can now select our baby's eye color or gender or hair color, I knew it's only a matter of time when we can finally have treatments specific to our disease and our genetic makeup. I thought, finally, we can have a cure for cancer. The impact of pharmacogenetic testing in disease outcomes is huge, as it would not only allow for swifter resolution of disease or illness and discomfort, but it would also help save time, resources, and tax dollars. Finally, I chose this because of our recent positive experiences with pharmacogenomic testing, utilizing gene site testing in particular. It is my hope that by the end of this presentation, you will be able to recognize the modifiable and non-modifiable factors that predispose a person to developing and worsening depression. I'm hoping you understand the many different diagnostic and screening tools that help in diagnosing depression, as well as treatment goals that help guide patient management. In this presentation, I hope you would be able to form an opinion on the nuances of personalized medicine and pharmacologic testing. Finally, through this presentation, I wish to exemplify the need to utilize evidence-based testing in treatment to ensure efficiency, quality, and affordability of care while incorporating a multidisciplinary approach in maximizing treatment outcomes. So, what is depression? According to the fifth edition of the Diagnostic and Statistical Manual of Mental Disorders, depression is a mood disorder resulting in persistent feelings of sadness or loss of interest. And the manual classifies it into five categories, which includes dysthymia, major depressive disorder, premenstrual dysmorphic disorder, and depressive disorder due to other medical conditions like Alzheimer's or Parkinson's. So, what is the um, common characteristic among these different classifications of depression? It's the feelings of sadness and emptiness, the irritability, and the somatic and cognitive changes resulting in a significant decline in an individual's ability to function. Know that about 60% of people with depression are not treated because of the stigma of mental disorder and the false perception that it is a social taboo and may interfere with personal and professional life. Now, what is personalized medicine and pharmacogenomic testing? In treating depression, the prescriptive treatment is determined on an empirical approach utilizing a physician's experience in combination with clinical indicators. This results in a trial and error approach to medication management. With the signature accomplishment of the most audacious and bold undertaking in human history, the Human Genome Project, thousands of researchers around the world from many different disciplines developed laser focused goals, causing a paradigm shift from one size fits all to individualized approach to medicine, from reactive to preventive. One of the tools utilized in personalized and individualized medicine is pharmacogenomic testing. The test helps identify the proper antidepressant or the proper medication for a person by determining how their body metabolizes certain drugs. The information the test provides help care providers like us avoid prescribing antidepressants that could produce undesirable outcomes and adverse events. So let me introduce my patient to you. She is 28 years old, Hispanic female. She's married. She has achieved graduate level in her education. She is a daycare owner as well. And we will learn more about Taylor as we go along. So Taylor came in with persistent feelings of sadness and worthlessness, a weight gain of 20 pounds over 4 months, increased smoking. This is actually a follow up on her depression, which we suspected she had from Mexico for a very, very long time. But the formal diagnosis just happened a few days ago or weeks. Um, she is an established 28-year-old Hispanic patient, as I said, and she presented to follow up for the depression, which is a new formal diagnosis. She is accompanied by her mother and was first seen in July 2023 and was started on sertraline. The dose was increased from 50 to 100 at week 8, and she was recommended to follow up 4 weeks later, but this did not happen. Instead, the patient took herself off sertraline and because she started experiencing some tremors and some increased jitters from it. She was also on Strattera for ADHD, which was started at the beginning of the year to improve her focus and concentration. She also discontinued that. She also declined to start antidepressants at the same time as starting the Strattera. The psychomotor side effects stopped when she stopped both tablets, of course, and now she's back to feeling depressed and has gained 20 pounds over 4 months. She's been smoking more. This patient is adopted, and the adoptive mother reports that the patient may be suffering from PTSD from being taken away from her biological parents at age 10, along with her brother due to neglect and abuse. She was adopted at age 15 or 16, and the biological father is incarcerated. The biological mother has plenty of unknown health issues and is in and out of nursing homes. And the patient reports that she has been feeling isolated since being taken away from her biological parents. So this is the patient's past medical history, gynecologic, social history, surgical, mental health, family history, health maintenance. I have highlighted all those factors that could have contributed to the development and worsening of depression. Um, Most notably, the family history of depression from the mother, alcoholism from the father, the history of abuse and neglect in the family, within the family unit, and of course, the fact that she's a current smoker, smoking 1 pack per day since the age 13. Otherwise, she is very compliant with her vaccinations. She eats a regular diet. She doesn't exercise though. So I have tabulated all the risk factors into non-modifiable and modifiable risk factors. Taylor, being female and age 28, puts her at a higher risk of developing depression, according to Chand and Arif in 2023. Of course, we all know the role of genetics and family history. Now, among the modifiable factors, there's smoking, the lack of exercise, the history of PTSD, and of course, post-adoption depression. There is a thing, and we think this patient has this post-adoption depression. In her review of systems, she's negative for dizziness and confusion. She's positive for weight gain of 20 pounds, stress eating, sleep disturbance, and lethargy. Her mood is depressed and anxious. She has very little interest in doing things. Her screening's PHQ-2 is 5. Her PHQ-9 is 21, which is very high and is considered severe depression. Her GAD scale is 17. She has an inability to concentrate and finish things. We know she has ADHD. Otherwise, all the other systems are good. PHQ-9 is a screening tool that we use, and they include or reflect the 9 DSM symptoms of major depression. And PHQ-2 items reflect depressed mood and anhedonia. So if you score high on your PHQ-2, you positive for depressed mood and anhedonia, usually the next thing is to do the PHQ-9, which includes questions on the interest, the depression, sleep problems, feelings of fatigue, loss of appetite, feeling like a failure, psychomotor agitation, and all those other symptoms. So Taylor denies allergies to medications, but she does have seasonal allergies, and she takes Zyrtec for her seasonal allergies. She also takes melatonin and clonidine to help her sleep. Clonidine She also takes for her ADHD. She also takes multivitamins and two common PRN medications, acetaminophen and ibuprofen. As for her physical examination, a lot of her vitals are marginal: 130 over 84, heart rate of 90. She's apyrexial. Her BMI is high at 28.3. She is unkempt. She showered 7 days ago. Afebrile. Her weight gain is apparent. Of course, her mood and affect are congruent, but they're blunted. She has poor eye contact. She's tearful, quiet, withdrawn, but she does volunteer answers. Her skin is dry and flaky. She has old scars on her upper and lower extremities, possibly from the abuse, I'm not sure. And of course, she has that central obesity. Otherwise, all the other examinations are normal. Because this is actually her third visit, um, a lot of the lab works were already done on the second visit, which included CBC, vitamin B6, B12, folate, and actually iron, CMP, A1C, and the thyroid function test. And these were all done to rule out other organic causes for depression, and they were all normal. So, what are my differentials for depression? Among the differentials are, some endocrine conditions like hypothyroidism and hyperthyroidism. There's the neurologic causes like dementia, CVA, Parkinson's, and Alzheimer's, which she doesn't have. First, she's young and she doesn't have the psychomotor signs and symptoms. Nutritional deficiencies: vitamin D, B6, B12, iron, and folate deficiencies. All her labs are good. Psychiatric: she has generalized anxiety disorder. No schizophrenia because of the absence of delusions. There's no bipolar mood disorder. She's mostly depressed. It can also be a malignancy, HIV or syphilis, which we do not have any basis for. So we have come up with a diagnosis of clinical depression. So when treating a patient, it is always important to set goals for treatment with them. So among those that I have recognized or established are the recognition and having the insight for depression, addressing the underlying issues for the depression, the reduction of depressive symptoms through pharmacologic and non-pharmacologic means, the development of healthier coping mechanisms through cognitive behavioral therapy and counseling, and increased interest and ability to perform ADLs, basic ADLs. So my plan of treatment for this patient includes lab tests, CBC, CMP, TFTs, vitamin B6, 12, folate, and iron. They've already been done, and so I had to double check on those to make sure that there's no organic cause for the depression. We started the Strattera 40 milligrams daily in the morning to allow her to focus and concentrate. We started her on Lexapro 10 milligrams daily to start in the evening so that if she gets tired, she can just fall asleep. smoking cessation because it worsens depression, weight management through diet and exercise because we know endorphins are good for you and exercise stimulate the release of endorphins. And of course, we referred her to behavioral health for counseling and cognitive behavioral therapy. The problem is there's a big shortage of mental health practitioners, so we opted to start her on pharmacologic treatments because it could take a while before she gets an appointment with mental health practitioners. We have now opted to do a gene site testing on this patient because of the failed treatments with fluoxetine, Paxil, and sertraline. It's not just failed testing, but she has been experiencing a lot of side effects from antidepressants. So we're hoping the Lexapro works. But just in case, we want to make sure that we have the right medication for her considering she's a smoker. So for my evidence-based research, I have decided to read on the guided trial, which is a large participant and rater-blinded RCT. It is 24 weeks long, where 1,398 participants were randomized to either arm 1 with 717 participants using treatment as usual without pharmacogenomic testing, or arm 2 with 681 participants using a pharmacogenomic guided intervention. So the independent variable for this study is pharmacogenomic or gene site testing, and the dependent variable is the symptoms and the responses and remissions. So in conclusion, there's actually no statistical significant improvements in the mean symptoms. That's 27.2 versus 24.4, p-value of only 0.107 when antidepressants recommended by pharmacogenomic testing were used. But pharmacogenomic testing did significantly improve the response, which is 26.0 versus 19.9, with a p-value of 0.013, and remission rates 15.3 versus 10.1 with a p-value of 0.007 for patients with difficult to treat depression over standard of care. This does not necessarily mean that the guided care was not effective at identifying the right pharmacologic treatment for the patient. It just means that the guided care has been able to determine the medication that is better tolerated by the individual with less side effects, that if taken for a prolonged period of time, more than 8 weeks, shows promise of a longer remission. That's what it means. And so, to conclude my presentation, here's my reflection. I think the future of medicine will be predictive and preventive. With pharmacologic testing, the safe, responsible, and optimal use of health information and test results required for personalized and individualized medicine will make us more informed, empowered, and accountable care providers. This means savings in terms of time, of resources, and tax dollars. Hood and Flores postulated that in the future everyone will have their genome sequenced and reviewed yearly for new actionable variants, organ-specific blood proteins that will be analyzed throughout life, and the system's approach to the immune system will enable the prediction of potential future occurrences of disease-perturbed networks in patients, and therefore render the whole medicine more preventive. The end is near for empirical dosing of pharmacological agents now that pharmacogenomic testing is here. It is only a matter of time until the prescribing guessing game is over. So with that, I finished my presentation, but before I go, I pose a couple of questions for you. So number 1, what do you foresee is the downside to pharmacogenomic testing, if any? Are there any ethical implications for pharmacogenomic testing? And second, do you have any recommendations to add to make the plan of treatment more comprehensive? How would you manage the patient differently if you will manage them differently? Thank you very much for your time, and you have a good night and happy graduation to those who are going to graduate. And here are my references.